Hi, one and all. Welcome to EM Rapid 2022 revision series. And today's topic is acute liver failure. When I say acute liver failure, we will be limiting our discussion to acute liver failure in adult patients and will not be dwelling too much into acute on chronic liver failure, but acute liver failure only. So these are the broad headings under which we will be discussing this session. That is moving on with the definitions, causes of ALF, clinical presentation, the predominant investigation strategies, the prognostic and decision scores, and management both in terms of etiology specific management and the general management principles. So what is the definition? So the definition is given by the most accepted definition is from the AASLD, and their ALF can be defined as a life-threatening condition of rapidly deteriorating liver function, and this is characterized by these four things. One is an INR above 1.5. Two, a neurological dysfunction with any degree of hepatic encephalopathy. So as you all know, there are 4 degrees of hepatic encephalopathy. And third is there should not be any prior evidence of liver disease. So and the disease course should be less than 26 weeks. So these are the 4 parameters which are required to call or to say that a patient is having an acute liver failure. So again, moving on to the classifications, as you all know, we have broadly classified into 3. That is your hyperacute liver failure, the acute liver failure, and the subacute liver failure. This is predominantly based upon the duration. So in hyperacute will be characterized by severe coagulopathy plus moderate intracranial hypertension and progression of jaundice to encephalopathy typically in less than 1 week. So that is the key thing here. So the progression from jaundice to encephalopathy, if it is happening in less than 1 week's time, we call it as hyperacute. Then we have the acute. Acute is where, again, moderately severe coagulopathy to mild to moderate intracranial hypertension and progression of jaundice to encephalopathy in 1 to 4 weeks. And a subacute is where there will be usually mild coagulopathy plus severe jaundice and progression of encephalopathy happens in the period of 4 to 12 weeks. So, and one of the commonest reason where we find a drug subacute ALF will be a drug induced, while acute most commonly any etiologies can present, and hyperacute most of the common literature says it happens mostly with acetaminophen or paracetamol toxicity and acute hepatitis A and E. So again, depending upon the various grading systems, you have the O'Grady system where what we said, basically the hyperacute, acute and subacute. Then you have the Bernau system where you have the classification of fulminant and subfulminant, that is from the jaundice to hepatic encephalopathy. If it happens in 0 to 2 weeks, it is fulminant, and from 2 to 12 weeks is subfulminant. And then you have the Japanese system where again you have the 0 to 8, which is fulminant, and 8 to 12 is late onset. And again, within the fulminant, they have classified 0 to 1 as acute fulminant, and 10 days to 8 weeks is more or less subacute fulminant. So at the end of the day, you should know that there is a broad classification into hyperacute, acute, and subacute. So causes. So again, as I said, we are limiting our discussion to only ALF and not ACLF. So the most common causes has been paracetamol toxicity, mushroom poisoning, drug-induced liver injury, rodenticide, especially with zinc phosphate. Then you have ischemic and cardiovascular causes like ischemic hepatitis, hypoperfusion-related liver failure, cardiogenic shock, other vascular causes like Buchiari syndrome, and sinusoidal obstruction syndrome. Then you have infections. This is again a very, very common cause where you have patients with viral hepatitis A, B, D, and E, and herpes simplex infections, varicella infections, EBV, cytomegalovirus, and also tropical infections like dengue virus, leptovirus, scrub typhus, and malaria. And other reason could be a pregnancy-related condition, which could be an acute fatty liver of pregnancy itself presenting at the ALF. The HELP syndrome, which is characterized by hemolysis, elevated liver enzymes, and low platelets, and also rarely liver rupture associated with preeclampsia or even HELP syndrome. So broadly, we have to classify it into drugs and toxins, your ischemic and cardiovascular causes, your infections, and also pregnancy-related conditions. So apart from that, you should also remember regarding the other conditions like Wilson's disease, which, as you all know, is an autosomal recessive disorder of ATP B7 incompatible copper transport, and Rey syndrome. Autoimmune hepatitis, yes, autoimmune hepatitis also there is a kind of increase of late, and then you can have malignant infiltration of liver and also primary graft non-function following a liver transplant. So this is from an NEGM article in 2013. I think things would have changed a bit from where it stood that point, where you can clearly see that the West, predominantly it is taken by, the proportion is taken by paracetamol toxicity, where in India it was predominantly a viral hepatitis kind of picture with B and E and A forming a major thing. But the reports from our own institution where ALF leading to transplants, we had a significant amount of patients who had from rodenticides, even ATT induced, other drug induced toxicities, which still form a major chunk of patients who have ALF leading to transplant. So this should give you a quick outline of what is to be expected based upon the geographical location. So clinical presentation, yes, I would rather bracket the clinical presentations on various organs, and so that it's easy for us to remember from head to toe kind of categorization. In the brain, as you know, the patient can present with hepatic encephalopathy features. There could be features of cerebral edema and intracranial hypertension. I'm not elaborating on the specifics, but these are the concepts which you need to keep in mind. From a cardiac point of view, it usually leads to a high output state, and also frequent subclinical myocardial injury can happen. From lungs, patients can present with ALF as a presenting complaint itself could be an ARDS or an acute lung injury. From liver, as you know, the main organ which is here affected here, we can broadly classify the symptoms or the presentation based upon the underlying pathophysiology. That is, a decrease in gluconeogenesis can lead to patient presenting with hypoglycemia. A problem with lactate clearance can happen because of hepatic failure, which can lead to lactic acidosis. There could be problems with ammonia clearance, which can lead the patient to present with hyperammonemia, and a synthetic capacity is lost, leading the patient to have significant coagulopathy and bleeding manifestations. Other organs which could be included is pancreas. Of course, pancreatitis with patient with inadequate glucocorticoid production contributing to hypotension with adrenal gland. Kidney, very often we find patients presenting with acute renal failure along with ALF. Bone marrow suppression can happen. Circulating leukocytes, there should be very prone to other infections. Portal hypertension may be prominent in subacute disease and may be confused with chronic liver failure. So even in acute, the patient, you remember that patient can present with portal hypertension and other systemic inflammatory response with high energy expenditure or rate of catabolism. So the clinical features, if you can remember based upon the broad organ involved or the system involved, it'll be much easier. We'll move on to the investigations. We'll start with the complete blood count, where the patient may have presented with thrombocytopenia and low HP. Elevated WBC could be an indication of an underlying infection. Your coagulation studies look at the PTINR, which is expected to be elevated. Liver function test, your liver enzymes predominantly, and ALP. And during the initial phase, of course, the patient usually presents with an elevated SGOT and SGPT. But in later phases, a decrease in SGOT and SGPT cannot be attributed to an improvement, but rather than a significant worsening of liver failure. Serum bilirubin can be elevated. Ammonia, yes, as you all know, it can be dramatically elevated, but there is not always a direct one-to-one correlation between hepatic encephalopathy and ammonia, and an arterial ammonia is considered to be more accurate than the venous ammonia. The patient may present with a low glucose level, and arterial lactate is often found to be elevated. And patient might have hypoxemia as revealed in the ABG. Other electrolyte abnormalities including hypokalemia, hyponatremia, hypophosphatemia can be found. Creatinine may be elevated, and of course, if you suspect any infections, blood cultures should be sent. From an etiological point of view, your investigations will involve a toxicological screen for screening both urine and serum, and if nasogastric aspirate if indicated for all suspected hepatotoxic agents. If Wilson's disease is suspected, look for serum free copper and ceruloplasmin. If paracetamol is toxicity is suspected, of course, ACETAMINOPHEN levels. Also run a drug screen in patients especially with intravenous drug abusers, and the virological screens, serologies for hepatitis A, that is your A virus immunoglobulin IgM, HPSAG, B IgM, anticore IgM basically, your hepatitis C viral load testing, and hepatitis D IgM if HBsAg is positive. In post-transplantation or immunocompromised patient, consider tests for CMV viremia or cytomegalovirus antigenemia, and also herpes simplex virus. And if there is a suspicion of autoimmune etiology for ALF, then do look for ANA and ASMA and immunoglobulin levels. Moving on to other investigations, yes, a patient with hepatic encephalopathy ideally should undergo a CT brain, because we should not be missing an intracranial bleed in such patients. But at the same time, other findings of raised intracranial tension can also be revealed in a CT. An MRI, of course, is not usually indicated, but might at times bring in extra information with regards to hepatic encephalopathy. Also consider an EEG, which can be used as a surrogate marker of the grade of encephalopathy. And upon admission, always obtain baseline echocardiograph and a liver ultrasound, and also consider CT of the liver to look for liver texture, volume, vascular integrity, and to exclude pancreatitis and presence of umbilical vein patency. So that is with the basic investigations. Before going into the management per se, we should all be aware about the prognostic scores and assessments which are used in managing ALF. So early recognition of patients who are unable to survive with medical management is important, because if you lose the vital time, then things might be too late. So it's very important that any patient who comes with acute liver failure, you do a prognostic scoring, and if the score is beyond a cutoff, it's always better to refer them to a transplant center or a center which has a backup transplant facility. So, of course, improvements in medical supportive care have increased transplant-free survival rates compared to the previous years with various presentations of ALF. And your American, the AGA has recommended to use MELD score over the King's College criteria. So, King's College criteria and MELD score are the two most commonly used scores for deciding whether the patient in ALF needs transplant or not. And as we said, the American AGA, that's American Gastroenterological Association, prefers MELD over the KCC. So MELD fixed cutoff of 30.5 should be used for prognosis, and usually a score of more than 30.5 predicts liver transplant. And the various parameters, here you can see the formula which is used to calculate the MELD score. Usually we use a digital tool which is available online for calculating the MELD score. And the parameters which are included are your serum bilirubin and INR, serum creatinine, and also based upon the etiology for the ALF. So as I told, AGA recommends MELD over KCC, especially because while KCC is more specific, but MELD is more sensitive, and MELD allows for optimization of specificity without losing the significant sensitivity. And as I told, if you have a score of more than 30.5, it usually predicts the need for liver transplantation. But the EASL, that is the European Association for Study of Liver, usually goes with the King's College criteria or the Clichy criteria. And this should give you a quick outline on the King's College criteria and the Clichy criteria, where King's College criteria again has two. That is, one, if it is based upon the etiology is paracetamol, or if it's non-paracetamol related ALF. So for paracetamol related ALF, you have to have an arterial pH of less than 7.3 after resuscitation and more than 24 hours of injection of PCM, a lactate of more than 3 millimole, or the three following criteria, that is a hepatic encephalopathy of more than grade 3, a serum creatinine of more than 300 micromole per liter, and an INR of more than 6.5. And non-PCM related, again there is a mild difference with INR of more than 6.5, with 3 out of the following, that is based upon the etiology: age between 10 to 40, interval between jaundice to encephalopathy of more than 7 days, bilirubin of more than 300, and an INR of more than 3.5. So either 3 of the 5 or your INR of more than 6.5 is usually considered, and then you have the Clichy score. So moving on to the major part, that's management. So the management principle, the key 3 principles in management of ALF are: 1, identification of the etiology of ALF whenever possible and initiate specific treatment. 2. Supportive and symptomatic management of ALF with timely referral to a critical care unit. And 3. Early consultation with liver transplant specialist and transfer of patients to a liver transplant center whenever necessary. So based upon the etiology, so if you have a patient with suspected or proven paracetamol toxicity, so when do you call it as a paracetamol toxicity? That is when the total ingestion is more than 7.5 to 10 gram. In India, we usually take as cutoff of more than 10 gram as lethal dose. Or in patients who are under high risk, even a dose of 4 to 10 grams might be lethal. So signs usually include a marked elevation of ALT more than 3000 and usually AST more than ALT. The ALT usually begins to rise at 24 to 36 hours of the overdose, and there could be relatively low bilirubin presentation and rapidly progressing disease with early metabolic acidosis, elevated lactate, and renal impairment are some of the characteristic features of PCM toxicity. And usually we have 4 phases of disease progression. But at the same time, you should remember that it could be either a single injection of a very high dose, or it could also be staggered dose. That's like, say, patient has taken 6 grams on day 1, 6 grams on day 2, 8 grams on day 3, and things like that. So it could be either a single fatal dose or a staggered dose. So this is something which is very, very crucial in deciding on the management part. That is what we call as the Rubach-Matthew nomogram. As you see on the below axis, you have the hours post ingestion of the PCM, and on the x-axis you will have the acetaminophen plasma concentration. So say this can be used for close to 36 hours. Say the patient had taken PCM at say 12 hours before, and we have a value of 150. So that will fall above in the higher part of the graph, which indicates that the patient will need a specific antidote. Or if it falls below the line, it says that we can wait and watch. So this is on which we base whether the patient will need NAC infusion or not. And NAC should ideally be started, and it's most efficacious if we start within 8 hours of ingestion. Yeah. So, as you told, regarding the management of acetaminophen toxicity, the one thing which has been proven to be useful is if the patient presents within early hours of ingestion, that is definitely within 1 hour, or at least within 4 hours of ingestion, there could be a role of activated charcoal. The usual dose, the recommended dose, is 1 gram per kilogram per body weight. And the specific antidote, as you all know, is N-acetylcysteine, which can be either given as an oral dose or an IV dose. The loading dose for intravenous is 150 milligram per kg in 5% dextrose over 50 minutes, followed by an infusion of 50 mg per kg given over 4 hours, followed by 100 mg per kg over 16 hours. There is also an oral dose as written below. You can all read that. But remember that even though the efficacy point of view both are same, on a practical aspect, we would definitely prefer an IV agent over an oral agent, mainly because most of the time the patient will be having vomiting, and again giving a large dose of N-acetylcysteine orally, and the patient vomits. We are not sure how effective that is going to be. Other thing will be a drug-induced hepatotoxicity, where it's usually a drug diagnosis of exclusion, and whatever, as common sense says, any drug which is causing ALF has to be stopped. And even though there is not much of evidence to say that NAC can be helpful, but there is a general practice to continue with or start the patient on N-acetylcysteine. Mushroom poisoning, yes, activated charcoal if the patient is presenting within the initial hours. A few drugs that has been proven specific to be useful in mushroom-induced ALF are intravenous penicillin G, a dose of 3 lakh units to 1 million units per kg per day, and silibinin at doses of 30 to 40 mg per kg per day, either intravenously or orally for a period of 3 to 4 days. And of course, there is some experimental role of RONAC infusion or your N-acetylcysteine also in mushroom poisoning. Viral hepatitis, yes. So with viral hepatitis A and viral hepatitis E induced ALF, there is no specific treatment and should receive supportive care. If it is in hepatitis B induced ALF, There has been proven benefits with antiviral agents, including lamivudine, and the use is recommended by AASLD. And the patients with documented or suspected herpes virus or varicella zoster infection as a trigger for ALF should receive an intravenous acyclovir. The recommended dose, as you all know, is 5 to 10 mg per kg IV every 8 hours for at least 7 days. For Wilson's disease, if the patient is presenting with a fulminant Wilson's disease, the patient usually requires transplant for a good survival, and treatment with penicillamine is not recommended in the setting of a significant hepatic dysfunction. Rather, hemofiltration via albumin dialysis or plasma exchange can have some role. We will come to that later. And regarding autoimmune hepatitis, yes, when the diagnosis is proven as autoimmune hepatitis, definitely there is a role of giving steroids. The usual dose of 60 mg per day, or a combination of prednisolone plus 30 mg per kg per day of prednisolone plus azathioprine 50 mg per day could be an initial treatment choice. And pregnancy-related ALF is usually self-limiting and after delivery, and is managed with supportive care, and very rarely might require liver transplantation. So moving on with the supportive and symptomatic management of ALF, the first issue to deal with will be hepatic encephalopathy. So the treatment goals with regards to hepatic encephalopathy are preventing the onset of hepatic encephalopathy itself, and slowing the progression and minimizing the development of cerebral edema and intracranial hypertension, which in turn could lead to cerebral herniation and death. The recommended gold standard for management, if you say, is always remains lactose. An initial dose, but its recommended dose is around 45 ml per hourly, followed by repeated doses every hour until the patient has an adequate bowel movement. Usually, as you all know, we target for at least 3 good quality bowel movements in 24 hours. If there's a risk of aspiration with oral lactose and lactose enema, where the dosing is 300 ml in 700 ml of water, so totally making it in 1 liter of the medicine, and it is retained as within the rectum for an hour, and repeat it every 2 hours as needed until the ventral functions improve. So lactose remains the cornerstone for remains one of the major lines of management for hepatic encephalopathy. There is a lot of interest on L-ornithine and L-aspartate, and we also use it, but at the end of the day, the expected mechanism is enhancing the ammonia detoxification to glutamine in the muscles. But if you purely go by evidence, there's not much of RCTs which support the use of LOLA. And if the patient is very comatose and not able to protect his own airway, intubation might be needed. The patient is delirious, sedation might be needed, and usual methods of head end elevation at 30 degrees, minimize interventions which could create a raise in ICP, and prophylactic use of anti-seizure medications is not shown or proven to be of much use, and medications which are commonly used in CLD may not be very much helpful in ALF, like your neomycin, rifampicin, or other non-absorbable antibiotics in particular. We use it for ACLF, but not very much proven benefit in ALF. And if the patient develops acute respiratory distress syndrome, of course, your traditional ARDS ventilation strategies need to be followed. Another key thing is hyperventilation. Now, we would have all noticed that patients with acute liver failure often present with a spontaneous hyperventilation, and this in turn might decrease the partial pressure of carbon dioxide in arterial blood, leading to a cerebral vasoconstriction, and which might benefit by decreasing in the intracranial pressure. But this effect is usually transient, and studies have shown not much of a survival benefit for hyperventilation, that's therapeutic hyperventilation in ALF, and hyperventilation is only recommended in life-threatening ICH when all other therapies have failed, and mechanical ventilation is often necessary in a setting of substantial volume resuscitation or significant encephalopathy. And the recommendation, I would say, is to maintain a low normal level of PCO2. Something like 30 to 40 should be an acceptable level of PCO2 in hepatic encephalopathy. Yes, at times intracranial hypertension might require aggressive management. The aim is to keep an ICP of less than 20 to 25 mm of Hg while maintaining the patient's cerebral perfusion pressure at about 50 to 60. So that means that you should be able to manage a good MAP and ICP to balance out the cerebral perfusion pressure. And some measures which has been proven to decrease the ICP is your hypertonic saline. Usually the recommended dose is around 20 ml of 30% hypertonic saline, but in our part of the world we go by the 3% saline. So a dose of maybe 200 ml initially, and then with a target sodium of around 150 to 160, 150 to 155 might be a reasonable way to go. Mannitol, of course, has been proven to have effect, but both mannitol and hypertonic saline, just let us all remember that the effect could be transient and rather help us buy time than a definitive intervention. Coagulopathy. Coagulopathy is another major challenge in management of ALF, but let us remember that there is no need to correct thrombocytopenia or an elevated INR by infusing plasma unless there is active bleeding or there is a need of a procedure. So patients with ALF have been shown to be deficient of vitamin K, and AASLD definitely recommends vitamin K in patients presenting with ALF. But conditions of coagulopathy correction with an FFP or a 4-factor PCC are limited to clinically significant bleeding or a need for an invasive procedure with high risk of bleeding, like an ICP monitoring or major surgery and things like that. And recombinant activated factor 7, if INR is markedly high and the patient requires a large volume of plasma to correct it, then probably a recombinant activated factor 7 could be considered. Thrombocytopenia correction, again, platelet less than 50,000 plus a clinically significant less than 50,000 with clinically significant bleeding definitely warrants platelet transfusions. Otherwise, for low risk procedure like central line insertion and things like that, we accept a cutoff of 30,000, and for moderate to high risk kind of procedures other than neurosurgeries, we usually accept a cutoff of 50,000. But in the setting of ALF and coagulopathy, GI bleed is a major concern, and those patients should definitely receive prophylaxis for GI bleed in the form of proton pump inhibitors, sucralfate, or H2 blockers. Infections, another major concern is these patients, as we discussed earlier, are very much prone to infections, and an empirical antibiotic is definitely indicated in most of the scenarios. The guideline recommendations usually is for going for a 3rd generation cephalosporin and vancomycin. So, but and the most common organisms there are GPC and enteric GNP. This is predominantly from the Western literature. In our part of the world, as you all know, it's more of like GNPs, even MDR GNP. So I would say the initial choice of antibiotic should be ideally tailored to the to what is prevalent in that geographical location, and we would rather go for a broad spectrum gram-negative coverage and not always an MRSA coverage, only if it is indicated, and definitely an antifungal cover in the form of fluconazole for candidiasis. And from an emergency medicine point of view, I would say that definitely you should draw a set of blood cultures and consider an antibiotic plus antifungal coverage for all high-risk patients in severe encephalopathy, renal failure, or a patient on mechanical ventilation. Renal failure is another major issue, and it's a very important role in prognostication of ALF. Identifying the underlying etiology for renal failure is very important, because as you all know, it could be a pre-renal failure which is accompanying the acute liver failure, where the treatment strategy will predominantly involve correction of hypovolemia, starting of vasopressors, etc. It could be a drug induced, as a drug which has insulted in ALF itself could be nephrotoxic also. So the management will be tailored in that direction. Other major thing would be a hepatorenal syndrome. Again, if the patient presents with it's mostly a diagnosis of exclusion, and if it is indeed a hepatorenal syndrome, then your management strategies will involve albumin, inotropes in the form of noradrenal, nortellipressin, and also if the patient is having intense ascites, probably tapping up of ascites and things like that. So a targeted management of hepatorenal syndrome might also be needed. Renal replacement therapy, of course, if the patient goes into renal failure, renal replacement therapy will be needed, and usually a CRRT is preferred over the conventional intermittent dialysis. And in addition to renal support, it might also be helpful in removing as a tool for removing ammonia and also other metabolic derangements. And the major issue, as we discussed earlier, is a correction of dyslipidemia, and patients most often present with severe hypoglycemia, and initial correction with 50% dextrose followed by an infusion of either 10% or even 25% of dextrose is usually indicated in patients with severe ALF. Cardiovascular support, again, ALF itself can lead to decreased systemic vascular resistance and elevated cardiac output. IV fluid resuscitation and vasopressor guided by the use of invasive monitoring is recommended. If the shock is refractory, always think about adrenal insufficiency as a secondary cause. In those kind of patients, will definitely benefit from steroids as recommended in septic shock, and a dose of 200 mg of hydrocortisone followed by followed by a daily dose of 204 divided doses might be indicated. Yes, the cornerstone remains if all medical measures fail, definitely a referral to a transplant center and early liver transplantation might be indicated. The key thing, as we discussed earlier, is an early decision and referral. It's beyond the scope of this topic to discuss liver transplantation in detail, but for the basic understanding, it could be either a living donor liver transplantation where the recipient liver is removed and a portion of a liver from a live donor is transplanted. It could be a cadaveric donor where liver in toto is taken from a brain dead patient and is transplanted into the patient, or it could be an auxiliary liver transplantation where a partial portion of the patient's liver is retained and a graft is taken from a donor and is kept, and with an assumption that the retained liver will regenerate in due course. A quick word about extracorporeal liver support systems. Yes, this is something which has gathered a lot of interest of late and is found to be useful. But at the end of the day, there is as we speak, there is very limited evidence for its use, and currently the recommendation is to use it in terms of clinical trials only. One thing is plasma exchange. It has been proven to improve transplant-free survival in ALF and modulate immune dysfunction, and it may have more benefit in patients when they are treated early. So one is plasma exchange. And other extracorporeal liver support systems we can broadly classify into artificial support systems that are cell-free and bioartificial support systems that incorporate hepatocytes with or without artificial support system. So in the first category, you have your conventional extracorporeal procedures like your hemodialysis, hemofiltration, plasmapheresis, or hemoadsorption. There is MARS, that is an albumin dialysis, such as your molecular adsorbent recirculating system, which is abbreviated as MARS. You can there is a single pass albumin dialysis. Then there is the promethesis, that is fractionated plasma separation and absorption. And among all these, only MARS and high volume plasma exchange have produced at least some evidence of benefit in ALF so far. And the bioartificial support systems, you have the extracorporeal liver assist devices and hepat assist. So this is a quick outline on something which is of interest and we should all be aware of. The differential diagnosis for a patient presenting with feature suggestive of ALF would be an acute liver injury, acute alcoholic hepatitis, acute on chronic liver failure, post-hepatectomy liver failure, and small for size syndrome. So I believe all of you would have got a good idea about the topic, and we started off with the definition, moved on to the classification of acute, hyperacute, acute, and subacute, then the various etiological reasons. Then based upon the geography, the etiology might vary, the clinical presentation, the prognostic or the diagnostic scoring, decision scorings, then the investigations in the form of generic blood investigations and also disease specific, etiology specific investigations. Then we moved on to the management with specific etiologies like paracetamol toxicity, mushroom, viral related, etc. And then we moved on to the general principles of management irrespective of the etiology, that's management of hepatic encephalopathy, intracranial hypertension, infection, coagulopathy, cardiac support. And at the end of the day, if none of the medical measures are going to work, the patient might need liver transplant, and a quick note of on the various extracorporeal therapies which are available for ALF. I hope all of you understood the topic well, and see you with the next topic later. Bye.